Good morning. I'm Dennis Rosen, one of the 3 pulmonary sleep attendings, and I've been asked to give you guys a pre-recorded talk about how to order sleep studies, a question which comes up a lot during your work, both on service and in the outpatient clinics. And hopefully this will help to organize your thoughts on how to order sleep studies and how to get the most out of the studies once they've been performed. So I'd like to begin by discussing what sleep studies are good for. Sleep studies are quite useful for identifying various forms of sleep-disordered breathing, which is going to be the main thrust of this talk. They're also good for identifying sleep-associated seizures, movement disorders in sleep, such as periodic limb movements of sleep, and some of the more rare sleep disorders, such as REM behavior disorder. But as far as we're concerned, certainly in this talk, the main thrust, the main focus of sleep studies that we're going to be ordering relate to sleep disorder breathing. And so as you think about ordering a sleep study, it's really important to consider what questions you're looking to answer. Sleep studies can identify various forms of sleep disorder breathing. These include obstructive sleep apnea, central sleep apnea, which can either be primary or secondary, primary being because of an underlying disorder and control of breathing, secondary being either because of an acute physiologic state, such as consumption of medications which suppress the drive to breathe, or because of varied physiology, which I'll address in a little bit, as well as periodic breathing. They can help identify hypoventilation or hypercarbia, and they can identify hypoxemia. And before I get into the actual ordering, I just want to review the differential diagnosis of hypoventilation, because again, I think it's really important to understand how to think about this so that when you go ahead and order the study, you can order it to provide the most useful information that it possibly can. So hypoventilation is defined as increased PCO2, which can either be measured in the blood or can be measured transcutaneously or with the greatest breath-to-breath sensitivity through end-tidal CO2. Hypoventilation is the consequence of decreased minute ventilation. Minute ventilation is the multiple of the respiratory rate by the tidal volume. It's important to remember that that's a good quick and dirty way of thinking about it, but it is important to recognize that within the tidal volume, there is a portion of the tidal volume which is alveolar ventilation. In other words, out of every breath you take, that portion actually participates in gas exchange versus that portion of the tidal volume which is dead space ventilation, which does not participate in gas exchange. And the reason this is so important is because if we consider the difference between a child who weighs 40 kilo and is taking tidal volumes of 10 cc per kilo, that you can see that in the column on the right. Out of those 400 cc, 300 cc are going to alveolar ventilation, 100 cc or 25% of tidal volume in otherwise healthy normal children going to dead space ventilation. And so that determines her ventilation. If her breathing becomes more shallow, either because of chest wall deformity, for example, or because of medications which suppress the respiratory drive, and her tidal volumes drop from 10 cc to 5 cc, the dead space remains the same. That doesn't change, but the alveolar ventilation drops by 2/3. And so in order to compensate, in order to achieve the same minute ventilation, the respiratory rate has to increase threefold. And so that's really important when we consider children who have chest wall abnormalities, children who are on medications, like I said, such as narcotics, such as baclofen, children who are who have vagal nerve stimulators, all of those things which can reduce the tidal volumes and therefore really hamper the alveolar ventilation. When we think about hypoxemia, it's important to consider that there are 4 main causes of hypoxemia. The first is hypoventilation, and hypoventilation directly correlates with hypoxemia. As you can see here, this is the alveolar gas exchange equation, and as the PCO2 increases, the PaO2, capital A O2, necessarily decreases. And so in a child who is hypoventilating, again, for any of the reasons which I have just mentioned and more, you may start to see hypoxemia consequent to that. You can have hypoxemia secondary to a diffusion defect. Examples of diffusion defect may be inflammation of the lungs, such as occurs when you have an acute lung infection, when you have an interstitial lung disease, when you have an acute aspiration event. Shunting, which typically denotes blood that bypasses the gas exchange portion of the lung and returns unoxygenated to the left side of the heart after bypassing the lungs, and a ventilation perfusion mismatch. And ventilation perfusion mismatch, I think, is one of the main causes of hypoxemia in the patients whom we see. And I think it's very important to consider this. And the reason for that is as follows. These are the respiratory volumes, which you are all familiar with, and you can see the tidal volume smack in the center. At the end of tidal exhalation is the functional residual capacity, which is comprised of two portions, the expiratory reserve volume and the residual volume. The expiratory reserve volume can drop either because we volitionally diminish it by exhaling further to as much as we can. The residual volume remains constant. However, there are factors which can affect the functional residual capacity. And these include many. For example, hypotonia, chest wall abnormalities in children who have low muscle tone to begin with and develop constipation, children who have gastric distension causing pressure up against the diaphragm. All these things can reduce the functional residual capacity. And the reason this is so important is because if you look at this graph, which demonstrates what happens as the functional residual capacity diminishes, you'll note that airway closure begins below a certain point. And what that means is that the smaller airways of the lungs begin to shut down, meaning that those areas of the lung don't participate in gas exchange. Now, as you know, the lung responds by vasoconstriction and preferentially diverting blood flow away from those areas which are not participating in gas exchange to areas which are participating so that they can absorb the oxygen and get rid of the carbon dioxide. However, these processes are uncoupled, meaning the airway closure and the vasoconstriction. And we can see this in many ways. For example, we see this in children who come to the ER with an asthma attack or given albuterol and their saturations drop. And that's because there is vasodilatation before there is return to gas exchange, normal gas exchange in those areas. And the same is true here. So if you have, if you have an airway which is right on the cusp of either closing or staying open, and it shuts down before the blood supply is diverted away from that area or is intermittently opening and shutting, you will have ventilation perfusion mismatching, and you will have a return of unoxygenated blood to the left side of the heart. And so this is really important. And one thing which is also very important to consider in this context is that body position has a really strong effect on this. So this is just a graph of a small study done in an English respiratory physiology lab. And you can notice the difference in the functional residual capacity between lying down supine, being in Trendelenburg with the head of the bed down. There's really almost no change in the functional residual capacity. However, once the head of the bed is elevated by just to a 30-degree angle, you'll notice that the FRC increases by 25%. It goes from 2 liters to 2.5 liters. And that's huge, right? And again, if you're talking about a child who's already compromised, elevating the head of the bed can increase the functional residual capacity and really improve the oxygenation. And because we define hypopneas partly by the drop in saturations in response to a decrease in airflow, this has huge implications for the patients whom we're seeing and how we might care for them or how we might craft a treatment plan for them. And this is just another illustration, again, from Dr. Nunn's book, which I very strongly recommend as a physiology textbook. And you can just see the difference between what happens to the abdominal contents when one is lying down versus when one is standing upright. And again, the pressure on the diaphragm really can cause an even further diminishment of the functional residual capacity. And again, this is something, and perhaps this is often a tangent, but it's something really important to remember when caring for children who have low muscle tone to begin with, children with CP, children with other issues, children with baseline hypotonia, such as kids with Down. It's very important to consider how constipation or gastric distension, or both, can have a profound effect on the respiratory system. So once we recognize that hypoxemia can be very sensitive to body position, we would need to think about how we improve body position in order to alleviate hypoxemia. And again, if you elevate the head of the bed to a 30-degree angle and you increase the functional residual capacity by 25%, you may eliminate the need for supplemental oxygen or for other respiratory support. So this is a big deal. So one thing one might consider doing is using a pillow. The problem with pillows is that they can cause flexion of the neck. And as you all know, when you go to resuscitate a baby, for example, babies who have short necks and big heads, the first thing that we do is put a towel roll underneath the shoulders in order to extend the neck, put the child in sniffing position, and keep the upper airway open. And so if you put a lot of pillows behind a child's head, you run the risk of causing the neck to flex and to block the upper airway, even if we're not talking about an infant, even if we're talking about a 10-year-old child. And that can cause upper airway obstruction, which in turn can cause a decrease in minute ventilation, as well as frank obstructive apnea in some cases. So a better way of doing this is to elevate the head of the bed by either elevating the entire head of the bed, or by placing, either doing that if you have a medical bed, or if you're doing a sleep study, to ask for the head of the bed just to be elevated. We have medical beds and can do that. If you're trying to recommend this for a patient at home, you might recommend using a wedge. You may also recommend taking a couple of blankets, rolling them up, sticking them underneath the mattress in order to elevate the head of the bed, keeping the head, neck, and back in a single plane and preventing flexion of the neck. So now we get to actually ordering the sleep study. So when you order a sleep study, this is what you're going to see. And the forms change every so often, but this is the basic thing. And by the way, when you get asked to order a sleep study for a patient in the NICU or a patient on GenPEDS-B, the answer is that they need to order the sleep study. You can help guide them and you can help suggest what needs to be done, but your job as fellows is not to put the orders in for a different service, nor is it your job to actually coordinate the study by talking with the sleep lab and talking with the sleep techs and trying to figure out when the study can be done. That's entirely their job. And at the top of the order form, you'll note the phone number for the sleep center, and that's a great number to give to the teams that are calling you and asking you to do all this extra work. So the first section is the type of sleep study requested. And so we'll just go over the different kinds of sleep studies that you can order. The first is just a regular sleep study, which would be diagnostic. You might do this if you're concerned about obstructive sleep apnea, central sleep apnea, hypoxia, hypercapnia. And this is this would probably be your first one. The second is a sleep study with a CPAP titration. And this would be ordered if you have a patient with known obstructive sleep apnea who needs to be started on CPAP. And I have some slides, I'll show you those in a minute, just detailing how you would complete that portion. But that's the study you would order if you know a child needs CPAP and you just need to figure out how much CPAP he or she needs in order to overcome the obstruction. The third type of sleep study is PSG with CPAP titration split night. A split night study is a study in which we start the child out off CPAP entirely, but add CPAP if she or he meets certain criteria. Our standard criteria are based upon adult criteria, which determine that CPAP will be added if more than 30 obstructions are seen in an hour for 2 hours, or 60 in total, right? So if a child has 60 obstructions in half an hour, they will start CPAP after half an hour. But if they have 30 obstructions in hour 1 and 35 obstructions in hour 2, they would start CPAP after demonstrating that they need it. Occasionally, you might choose to modify those guidelines, and you might say, well, this is a child who's been using CPAP for a while. The parents question whether he needs to continue using it. And so you might say, well, I think he probably does need it, and so I prefer to start him off CPAP. But if he has more than 10 obstructions an hour or 20 in total, I want to start him on CPAP and start either where he is on right now, or start him from 5, which is the lower limit of where we start CPAP from. That's where we begin, and titrate upwards to eliminate obstruction. One thing to keep in mind when you are doing a CPAP titration, well, there are a few things to keep in mind. One thing to keep in mind is that the lower the number of obstructions necessary to trigger CPAP initiation, the higher the likelihood that a technologist running the study will identify obstruction and start CPAP, which ultimately are not necessarily agreed upon by the physician reviewing the sleep study. And it does happen that, or has happened that I've seen sleep studies in which the technologist started CPAP and I reviewed it and really didn't see, in retrospect, a reason for starting it. And so that's just something to consider. The other thing to consider is that while you might do this in an adult, certainly you could do this, or in an older teen, you'd really want to talk about this ahead of time, because being woken up after sleeping for a couple of hours, having somebody come at you with a mask, putting on your face and starting you on CPAP is not necessarily, it can be quite scary and quite anxiety provoking. And many of our children have developmental delay or have underlying anxiety. And so I usually don't order split night studies except in people in whom I have a high likelihood of suspicion of the high likelihood of the presence of obstructive sleep apnea. And I typically discuss this in advance. I explain to the teenager, because it's almost always teenagers, what CPAP is, what it entails, what might happen if they have severe obstruction. And I tell them that if they choose not to have it put on, it is absolutely fine, and they don't have to do it. They can decline. The next is PSG with BiPAP titration. This is typically used for children who have hypoventilation or children who need respiratory support. And because these are much less standardized, you will need to think about what it is you're trying to accomplish and write out a very clear set of guidelines for the technologist as to what it is you're trying to accomplish. And so, if you're talking about, if you're trying to control hypoventilation, then you would want to put in target carbon dioxide levels. If you're talking about hypoventilation and obstruction, you would want to control obstruction first, and then you would want to control hypoventilation. And if there remained hypoxia at the end, you might, once the other two components of the sleep disorder breathing were controlled, at that point you might want to bleed in supplemental oxygen into the circuitry. But again, these are more complex. PSG with tracheostomy, these are typically studies in which a child has a tracheostomy and there's consideration being given to removing the tracheostomy. And so the question is, can this child sleep with the tracheostomy capped, essentially mimicking a night without a tracheostomy, and see whether or not he or she can manage with this. The next is sleep study with oxygen titration via nasal cannula. To be honest, I don't think you really need to order these. I think if you have an inpatient, it makes more sense to get an overnight oximetry study and do it that way. You really don't need the EEG. You don't need the other components that a sleep study can give you. And as you may know, it takes a long time to schedule sleep studies sometime. And you can get an overnight oximetry study like that. Just call down to the PFT lab. If you have a child who is already on oxygen at home and you want to see whether or not you can wean them, it's probably better to get an overnight home oximetry study through the durable medical equipment company that supplies the oxygen, and then to base your conclusions on that. So my suggestion, I never order sleep studies with oxygen titration, and my suggestion would be to use that sparingly. The final are multiple sleep latency tests or maintenance of wakefulness tests, and these are studies to assess for narcolepsy or to assess for efficacy of treatment for narcolepsy, and I'm not going to go into details about that. Then the next field you see is the attending to receive results. That should be the attending on service or the attending with whom you're working. So if you're seeing a patient in the outpatient clinic, then that would be your preceptor. If you are on service and you're ordering a sleep study for a patient on your service, then that would be your attending. And if it is a patient on another service, that would be their attending. You can certainly put your name in on the ordering provider if it's your own patient, and that will guarantee that you will get a copy of the report, because ultimately you want to get a copy of the report. And then priority. So there are 3 settings. One is routine. Just so you know, we triage patients based upon their medical complexity and the predicted need for 1-to-1 ratio, 1-to-1 tech to patient ratio versus 2-to-1 ratio. The more medically complex a patient is, the farther out we're scheduling. Currently, we're scheduling about 5 months out for medically complex patients, which is quite challenging. But that's what the routine is. Urgent outpatient, that would be if somebody you have a very high suspicion of sleep disorder breathing, somebody who is going to have surgery, and decisions need to be made based upon the results of the sleep study. A person who's already been diagnosed with obstructive sleep apnea and in whom you need to get treatment quickly. And then currently inpatient. And for that, once you ordered it, it would be important, again, if it's your service, for you to page or have your team page the sleep fellow or the NP. We currently don't have sleep fellows in-house, although I think in 2019-20 we are going to have a sleep fellow. But in any case, there's always a nurse practitioner on call. Page the nurse practitioner and let her know that we are ordering an inpatient study. If it is on the weekend, what you would want to do is you would want to, after you place the order, you would want to go into Outlook. You will type in sleep and then click on check names. You'll get a drop-down menu. You want the sleep admin. You want the sleep nursing. That's where I'd start. And if you want to remember, but you may not remember, Michael Ganusio is the chief tech, and he's always on call. And if you look it up, you'll see it like on the call schedule. And if you send an email to those 3 saying, we've placed an order, we'd like to get this done ASAP, even on a weekend, it will register and it can start to be processed first thing Monday morning. And that way, it's already being dealt with. Once you've selected the sleep study, you'll get this window, and it talks about initiating guidelines. You can either use the standard guidelines, the modified guidelines, or something else entirely. The standard guidelines basically state that if the oxygen saturation is less than 85% for greater than 5 minutes or less than 80% for greater than 2 minutes, then you want oxygen initiated at a flow rate of quarter liter per minute, and then increased by quarter liter increments to maintain SpO2 values of greater than 92%. And that's sort of our across-the-board standard. Now, if you have a patient with pulmonary hypertension, then you may want to change this. You may want to make the guidelines more stringent. If, on the other hand, you have a patient, or you're consulting on a child with a cyanotic heart lesion who SATs 86%, all the time and feels good with it, you may want to change those guidelines as well. So this is what you would do, and you have to fill this out in order to continue with the ordering process. This next screen shows the additional information and instructions window, and this is really, really important. So what I would suggest is you write down here. What I typically write down is just a quick brief information, why this kid's being referred. So it could be 3-year-old with Down syndrome, snoring, concern for obstructive sleep apnea. The next line I write is typically elevate head of bed, position in order to alleviate obstruction, because as I mentioned earlier, positioning can have a really strong effect on on a child's breathing, both in terms of oxygenation as well as opening up the upper airway, if they do have upper airway obstruction. And so if you're, for example, ordering a study in a child who's already had their tonsils and adenoids removed, if you're able to treat them by positioning, it may be a lot easier for them and for the family and for everybody to do that rather than use CPAP. So that's my next thing. The next thing I write is I typically want to read my own studies, so I typically plug in here Rosen to read. If you have concerns about the patient, if it's a complex patient, if you are following this patient with one of the three of us, Umakant, Elliot, or myself, and you'd like us to read it, you can write that down. And so that can be quite helpful because then you're getting our input into this as well. It can be quite challenging to order a sleep study and then to have it read by somebody else, not be quite sure about what the interpretation was, and then come back and start asking us questions about what that means. In order to really answer those questions, we need to go back and review the sleep study frame by frame, and that's quite time consuming, and ultimately it's not something we can do on a regular basis. If the parents are inclined to be on the cancellation list, if it's a patient you're seeing in the outpatient realm and the parents say, I will come whenever you call me, then mark that down as well. It is not uncommon, even with our long wait list, for patients to be seen on a Thursday and have a study done on Friday because there are always cancellations. So you can mark that as well. If you would like to see the patient back in clinic, then you might put a note here for the sleep text to email you with the date of the study so that you can then take that date and try and schedule a follow-up appointment for a couple weeks afterwards. Typically speaking, if you want to review the results of a sleep study with a family, you want to see the child back. You want to give yourself a couple weeks for it to be interpreted, because if it's what we consider a red flag study with severe obstruction, it will be scored and read quickly. But if it's a routine study and there's not really much of anything, it may take up to 2 weeks and sometimes even a bit longer for it to be interpreted. If you are doing a CPAP study, you might think about rescheduling the child to come back and see you 3 weeks after, because you're going to get the CPAP study interpreted. You're going to order the CPAP. It's got to be processed by insurance. They have to pick it up. Ideally, you'd like the family to have tried to use the CPAP at least for 1 or 2 nights, and then come back and see you with the CPAP so you can troubleshoot any issues. So all of these things here are really helpful. And again, the more information you put here, and certainly for the text as well, the more likely you are to get the information that you're looking for. Next field is indications for study. Hypersomnia is more narcolepsy, but if you're concerned about hypoventilation, obstructive sleep apnea, central sleep apnea, intermittent hypoxia, all those things. Again, the more information you can provide, the better. Primary symptoms, pretty self-explanatory, so I won't go into that. And again, if there are things that you think would be helpful for the interpreting physician to know, or for the schedulers or for the text to know, please put that information in there. Special considerations, if this is a child with significant anxiety, for example, you might want to mention that so that they can have a lab tour and help allay some of their anxieties. If you are ordering a CPAP study and you do not know how the child will tolerate wearing a mask, it may make sense to have them come for a mask fitting with one of our sleep techs, to be fitted for a mask, to be given the mask to take home, and then to be able to play with it and wear it at home, get used to it so that they won't be scared when it is put on their face the night of the sleep study. So all this information, G-tube, tracheostomy, all this information can be very helpful and useful in order to schedule and again make sure we get the most out of the study. Tonsil size can be helpful as well. So for example, if you know that the child has huge tonsils, let's say it's an 8-year-old with snoring, gasping, witness pauses in breathing, and you are highly concerned about obstructive sleep apnea, but the child has huge tonsils. If you mark that down, that can be quite helpful, because that will then inform the covering physician's decision, for example, when she or he gets the phone call in the middle of the night saying this kid has really bad obstructive sleep apnea, would you like us to implement split night criteria and start him on CPAP? For the physician to say, well, this kid has big tonsils, he or she is going to get their tonsils taken out as the first step, and they've already been plugged in with ear, nose, and throat, so we probably don't have to start them on CPAP. So the more information, the better. Adenoidal hypertrophy as well. Baseline saturation, again, sort of comes back to what I was talking about earlier. If you've got a kid who has underlying lung disease or heart disease, it just makes it easier for the on-call team to manage the child in real time. At the very bottom, you can see mask desensitization needed. Again, what I was talking about. If you think that that might be beneficial, I typically just put it in my instructions, but you can use this checkbox as well. And then, of course, explain what it is you're looking for. If you are starting CPAP, so you've ordered a CPAP split night, again, as I mentioned, the standard protocol, as soon as you click on that, the standard protocol comes up and it says, as I mentioned, 30 obstructive events an hour or 60 in 2 hours. That's when you start CPAP at 5 centimeter water and titrate up to eliminate obstruction. However, if you have a child who's on CPAP, currently using it at 7, and you want to make sure that they are appropriately titrated because they've put on weight or it's been 2 years since they were last titrated, you might say, if they have 10 obstructions an hour, then start them back on at 7. If you might also say, I want to start them on 7, but if they're having obstruction, I want to jump right up to 10. So this allows you to really dictate your requests. And then, as I mentioned, if you're ordering BiPAP, it's really important to write out a step-by-step plan. So, again, because obstructive sleep apnea, by causing upper airway obstruction, can reduce minute ventilation, it is not uncommon to see children with severe obstructive sleep apnea also having hypercapnia. And if they have hypercapnia, they often have hypoxia. And so because of that, if you're going to start treatment, you really need to think about how you're addressing all of these appropriately and in a stepwise manner to make sure they're all being treated. So, for example, you might write the following. Draw venous blood gas at beginning of study, correlate with end-tidal CO2 and transcutaneous CO2. That will allow you to be able to follow in real time and know what a difference there is. Start BiPAP at X settings with a backup rate of Y. So X settings, if you're treating obstruction, typically when we put somebody on BiPAP because of obstruction, we typically put them on once the CPAP, if they've used CPAP before, is greater than 12, or if there may be other reasons to do this, we need to go higher. Typically, when treating obstructions, we keep a fixed delta, so we might start with 10 over 4, and then start to ramp up to 11 over 5, 12 over 6, 13 over 7, and ramp up accordingly. However, if we are using BiPAP because of hypoventilation, we need to increase the minute ventilation. And so to do that, you would want a higher delta between the inspiratory positive airway pressure and the expiratory positive airway pressure. The reason for that being that by increasing the delta, you're going to increase the tidal volumes, and you would want to put a backup rate as well. Now, there are different ways of applying a backup rate. What I've been taught, and which seems to work very well, is to start with a backup rate of about 2/3 of the patient's resting respiratory rate. So if we're talking about a teenager who's otherwise well, who's, you might say is breathing anywhere from 16 to 20, you might start them with a backup rate of 12. And so you've started them on BiPAP. You want to titrate the BiPAP to eliminate obstruction if there is obstruction. And then what you want to do is you want to have them correct the CO2 if the CO2 is still elevated. And so what I would probably write would be start BiPAP at 12 over 6, increase in 1 centimeter water increments while maintaining a fixed delta until obstruction controlled. If end-tidal CO2 remains greater than 10 centimeter water above baseline or above 55 or 60, whatever parameter you want to use, then increase the IPAP, parenthesis, increasing delta, close parenthesis, and or rate per comfort in order to bring carbon dioxide levels down to your target. And it's important to recognize that if you have somebody who's hypoventilating but has chronic respiratory acidosis, where they have a pH of 7.34 and a PCO2 of 75, yes, you can use ventilation to drop their PCO2 to 45. But if you do that, you're going to throw them into respiratory alkalosis, and they're going to be really uncomfortable. And so, you really want to try and keep them within you don't want to drop them down all at once. And so you have to think about how you're doing that. And then once you have the obstruction controlled and the hypoventilation controlled, at that point you can start thinking about the oxygenation, right, which is already being influenced by the ventilation, which you've already controlled. And then at that point, if they have, for example, if they have an underlying lung disease as well, they've had recurrent aspiration, or they have bronchiectasis, or they have interstitial lung disease, at that point you might think about adding supplemental oxygen to be bled into the circuitry at a flow rate of X in order to maintain SpO2 values greater than Y. So it sounds complicated. It is complicated. And this is why many times people come and talk to Umakant, Elliot, and myself about this. And we're very happy to help. Really, we're very happy to help. We really like it when you think about the patient, come up with a plan, and then we can discuss your plan. I think it's much better for you, and it's ultimately better for the patient, and it teaches you how to think about this and approach this. And we're certainly happy to help craft it. There's almost always one of us on call for urgent studies. We have a system where there's a reader of the week who's either from the pulmonary sleep service or the neurology sleep service. But then there's a backup from the other service. So there's always somebody who can be reached. If I am the backup reader of the week, but I'm in clinic in North Dartmouth, I may not be able to get back to you immediately. I may be able to get back to you at the end of the day or the next day. But there's always someone to talk with. So it is complicated, and it does require thinking about the patients in a systematic way. But we are very happy to help you with this. And that's it. So welcome to pulmonary. Good luck with the sleep patients. I know I've thrown a lot of information at you. It sounds complicated. It is, but probably less complicated than it sounds initially. And you guys will do great. And really, we're here. The three of us are here, and really always ready to help you. Thank you.